Hello and welcome to another episode of Winning Healthcare Food Fights Without the Mess. My name is Hunter Schultz, your host, and this is part 3 of the 2020 Healthcare Buyer's Guide. Today I'm going to explore two important vital points related to all of our care. And we're going to talk about time and thinking time. And for me, these two episodes are pretty easy, because two of my medical mentors impressed upon me the importance of both. And they're distinctly different, but interrelated. And so, as we explore this, I'd like you to keep in mind that it's a common complaint. If you do the research on time, patient time, it's common in the United States that a lot of doctor visits are 8 minutes and out the door. And I'm really focused on primary care here because primary care is the linchpin. It is the Jesus nut of healthcare. Without primary care, great primary care, healthcare systems fail. And in fact, the rest of the developed world focuses on primary care. It's one of the reasons why they have better health outcomes. The problem is their specialty care can be lacking sometimes in terms of access, timely access to specialty care. The developed world in general is pretty good on catastrophic care. Heart attack, stroke, accidents. The developed world's at a very high level. And in fact, many of the developing world countries are doing a pretty good job with catastrophic type care. So we're really focused here on primary care. And in the U.S., common complaint, it's 8 minutes and out the door. And I'm basically told, go visit a specialist. And no wonder people are a little disenchanted, frustrated. They're disconnected from primary care. It's as simple as that. One of the reasons why, and we'll explore that, doctors are disconnected from the patient for a variety of reasons, some of which are EHRs, for instance, electronic health records. They have to keep track of billing codes. They have to keep track of the minutia of primary care. Why is that? Well, insurance, Medicare, they all have requirements, reporting requirements. At some point, doctors are audited. Someone has to come in and look at the electronic health record. That'll be the next episode. Someone has to come in and look at the diagnosis. Someone has to come in, usually a registered nurse, and check and see if the doctor's diagnosis is meeting the treatment plan and the billing codes. So a common complaint is time with the patient. And it's surprising. People come to Panama. When I arrived here 15 years ago, it was mind-blowing to have an hour with your doctor, a half hour. 8 minutes and out the door was unheard of. There was no rush. There was no doctors looking at their watches saying, we need to wrap this up. No, it was a lot more. There was a lot more listening going on, and it blew people away from the U.S. Other countries, not so much, but the U.S., absolutely. Why is that? Well, the rest of the developed world focuses on primary care. It's a simple fact. The only country that doesn't focus on primary care is the U.S. The system is actually weighted against that important element of healthcare. Hence the reason you go in and you have an 8.5-minute appointment. The doctor is in their computer. I should say 8.5 minutes FaceTime. And they may spend another 5 or 10 minutes actually paying more attention to their computer than you. They're putting in billing codes. They're putting in their diagnosis. They're putting in their treatment plan because that's an important element. They don't get compensated. And when they are audited, when they're audited for financial compensation. In other words, does what you tell the doctor match the diagnosis and the treatment plan? In other words, you go into your doctor and you have a runny nose, but the billing charge to Medicare or Medicaid is for something far more serious. Well, they're audited for that. They're also audited for quality metrics, the quality of the system they're using. That is for the next episode, but it's something to keep in mind. So a lot of what's driving the time away from the patient is driven by government regulations, starting with Medicare and Medicaid. It's fair to point out that when Medicare and Medicaid were first started, but I'll focus on Medicare because that was a much bigger element. When it first started, it was all about hospitalization. It wasn't about primary care. In fact, in JFK's speech in '62, he talked about universal health care, but he made it a point to say what he was talking about, what he was looking for, was not like what England was doing and other countries. He was talking about people who were 65 and older. It's in his speech. The whole speech was about 30 minutes long, and I'll have it linked below. And he talked about how, rightfully so, by the way, no one with a heart is going to deny someone care if they're needy and it's something that has to be done. It's how you do it. But even President Kennedy pointed out it was hospitalization can just crush someone's finances. They work long hours for a long time, and they might have $3,000, $4,000 in the bank, and they're crushed with a high hospital bill. He was pointing something out. Primary care back then was cheap, and it was paid for in cash. There was something else at work, too. Keep in mind, medicine back then was simpler. It was easier. It wasn't as complicated. I'll get to that in a minute. But doctors had plenty of time back then to think, to listen to you, listen to the whole you, where you live, where you work, where you play, how you do those things. They knew you. It's not that complex. We don't have that now. There's no time. So now we have this administrative state. When did that happen? Well, Medicare started out simply as hospitalization for the elderly. And if you read the original act, the Supplemental Social Security Act of 1965, you'll find that it's all about hospitalization, because back then that's where the real price killer was. There wasn't as much specialty care. There weren't as many specialists. In fact, the ratio changed. Back then it was about 70-30, 70% primary care to 30% specialists. Now, more like 35-65. Big difference. So Medicare started out covering hospitalization. Not long after that, not long after it was created, primary care was covered. And that's the beginning. Hence the reason you go into your doctor's office and you see a whole bunch of people sitting behind a counter doing admin work. What are they doing? They're actually doing billing and claims reimbursement for insurance and Medicare. That's what they do. That's a big overhead for a physician office. 30-40% overhead. So keep that in mind next time you walk into your doctor's office. And I might add, in the last episode of the show, Dr. Creighton Shute described that. And I think his words are pretty important here.
At the end of the day, I'm also a daddy, I'm a husband, and sometimes I'm a patient too. And just like everyone else, it's a very frustrating experience for me to walk into a doctor's office 15 minutes ahead of my appointment time, show up, walk up to the little frosted window that says, don't tap on the glass, ring the bell. So then you ring the bell and they open the window annoyed that you've done that, and ask you what you need, and you say, well, I'm here for my appointment. And they hand you a stack of papers, and it's the exact same stack of papers that you filled out the last time you were in that exact same office. And so then you spend 10 minutes filling out that stack of papers, and you walk back up to the window, and you ring the bell more softly this time because you're trying not to annoy them like you did the first time. And they open the window the exact same way, and they say, sit down, and we'll call you in when it's your time. And then somewhere between 20 minutes and 60 minutes later, you finally get called back, and you get they use a set of vitals, and then they put you in this cold room that you're, sort of unfamiliar with. And they say the doctor will be right with you. And it's somewhere between 15 and 50 minutes that you're sitting in this room. And it feels like forever, right? Because you're sitting in a room and you have no idea how long it's going to be. And you can hear the doctor talking right outside your door, right? Because he's right next door, or, walking out of the room next door, and you're thinking, oh, he's going to come into my room next. And no, then you hear a door open and close across the hall. And so now you're waiting for a longer period of time. So then the doctor finally comes in, and he's very kind, and he shakes your hand and says, what can I do for you today? And you have your one complaint that you're allowed to go through, and he sits down and spends the next 7 minutes with his back turned to you while he's typing on a computer. And then you get a prescription, or you get an order for 3 more doctor's visits at other specialists, offices, where you get to go experience that thing over and over and over again. And he says, come back and see me in 6 weeks. Everyone experiences that. It's not like it's an accident that I can describe that and people laugh about it or shake their heads about it or cry about it, because everyone's experiencing healthcare in exactly the same way. And so the short way to say that is that you spend an hour of your time to get 5 minutes with your doctor.
So Medicare started with hospitalization. They brought in covering primary care, where all the minutiae is, by the way. Primary care is most of the care we receive over our entire life. It follows that with more and more regulations, and by the way, insurance companies take their cue from Medicare. What they do is they're not reinventing the wheel. They're not idiots. They're taking what Medicare does, and they say to the doctors and the hospitals and providers, they say, fine, instead of a $10 for this, we'll pay you $15 or $20. So a lot of the regulations created by Medicare are duplicated by insurance companies. And then there are more than one insurance company. So you need more people to handle their different claims processes. Hence the reason why a doctor might have 3 or 4 people handling specific insurance company claims. That doesn't seem real smart in the primary care space, especially. That's an important distinction. So there's majesty and simplicity, as Dr. Shute and Melissa Jones and a lot of other doctors who've been on the show have pointed out, that their practices are simple, they're easy. There's no regulation involved. It's just their patients and the doctor. So there's majesty and simplicity. Medicine, the relationship was lost over time, and it's been a slow process. This didn't happen overnight. It wasn't the fault of Obamacare. It started back in 1965 and then grew from there. And any doctor who's been around long enough will laugh when they look at the first paragraph of Medicare, the act which created Medicare back in 65. And here it is. Nothing in this title shall be construed to authorize any federal officer or employee to exercise any supervision or control over the practice of medicine. Note those words, that government will not interfere with the practice of medicine. Point that out to your doctor. Show him this part of the video. See what she says. See how they laugh. Because government didn't live up to that. And as soon as they got involved in primary care, the game was over. Insurance followed. But there's something else that's happened. And the relationship has been lost over time. And I probably repeated that, but it bears repeating. Medicine, healthcare, requires a strong, trusting doctor-patient, patient-doctor relationship. Has to be that way. Anything else is a failure. Something important to look for when you're looking for great healthcare too. What we have is more of an assembly line approach. It's gotten to be a take a number system now. 60 years ago, as I said, things were a lot easier. You didn't have as many variables. And what are those variables? This is a critical point. 60 years ago, you didn't have MRIs. You didn't have telemedicine, blood tests, or as many blood tests. Didn't have CAT scans. You had X-rays. But doctors were pretty limited in what they could test for. Now you have an explosion of medical data, research, which is doubling at least every 6 months now, and probably even faster than that. And this has all happened within the last 20 years or so, a lot of it anyway. So the variability has increased over time and has rocketed, absolutely rocketed upwards since the year 2000 when the first human genome was announced, the sequencing. Doctors at that point knew the game was up because now it was personalized care, which we'll cover in the next episode. Which leads me to this point. With all these variables, and any assembly line worker can tell you, with all these variables, something's got to give. In a production line, if you increase variability, the line has to slow down to accommodate the changes, the variability. So it follows that in medicine, if you didn't have as much variability to deal with, the process was pretty quick. You could spend more time on the relationship. Doctors had less to be worried about. There were less dots to connect. There were a lot of unknown unknowns at that point. Now, not only do doctors need more time with you to understand the environment in which you live, work, and play, the stressors that you're encountering in your daily life, but they need time, more time, to reflect once you're out of the exam room or off the phone with them. They need time to think. They need time to connect the dots. They need time to look at your diet, look at your exercise schedule, look at your blood work, your other tests, look at your genome. Where's that time going to come from in the current system? And even a few proposed systems, I haven't found it. And I doubt you will either. Correct me if I'm wrong. Comment section is open. So doctors need more time to think. How will they get compensated for that? That's a good question. How do they prove that in the audit process? Oh, I sat and thought about patient Jones for 55 minutes. Is government going to trust that? Do you think there's room for abuse there, regardless of it being audited? And by the way, if we're talking about government-run healthcare, that's going to be audited. Simple fact, taxpayer money. Again, the GAO isn't going to allow $3.5–4 trillion, whatever that $1 trillion figure is. They're not going to sit back and say, "Oh no, we trust everyone." Not really. So as a summary, doctors need more time to listen to us patients, to absorb what's going on. And they need time to think, not only while we're there, but think about the variables. And there's so many of them. The blood work, the medical research, genome, gut microbiome, things I mentioned before. Either the system is going to enable that or not. So a couple of questions you might want to think about. Since this is process related, it follows that today's primary care doctors who have 2,000 to 3,000 patients in their panel size, it's simple arithmetic with time. They see 1 to 2% of their patients per day. Do the math. We're only talking about 10, 15 minutes a day for each patient. Now, granted, some patients are simple. You know, it can be handled in 5 or 10 minutes. But if you only see that patient once a year, there's a big opportunity that's lost. An opportunity to learn more about them. What's going on? What kind of stress is going on? If they're under a lot of stress, how's that impacting their health? So there's a missed opportunity for the doctor to connect because of the time limitations. So the ideal patient panel size is more towards 500 to 800. And what drives that figure, that range, is Medicare patients, for instance. They require more time. They have more complex issues. They have more issues, many of them. And it takes more time. So 500, 550 patients, they have the time to do that. It might be an hour-long visit because they're doing more education too. It's not just listening, it's educating. Something I probably should have mentioned earlier. But still, older people, I'm one of them, we're going to have more issues over time. Simple fact of physiology. Aging. We can delay that. Steve Schimpf's book, Longevity Decoded, good place to start. So 500 to 800. 800, doctor has a lot of younger patients, primarily younger. Maybe the mix is 10, 15% Medicare aged patients to 600 younger patients, 30s, 40s, 20s. It's simple arithmetic. It's not complex math. That's one important thing you have to look for. How are we going to get patient panel sizes under control? How will your plan, senator, congressman or woman, how will your plan reduce patient panel sizes so that doctors have more time to think and to listen? How will any new system, any proposed new system, increase the amount of listening time, amount of patient time, sitting in front of a doctor in an office visit from 8 minutes to what it should be? Where is it? Where is it in the plan? Don't be shy about asking. The odds are they're not going to know. Seriously, they won't know. They're so focused on coverage. They're so focused on paying the bill. They've missed an important point. You got to get the care right. If you don't get the care right, you're wasting your time and a lot of money. How will any new system increase the doctor's ability to think about a patient and be paid for it, frankly? How are they going to account for that? How will we increase the ability for a doctor to think about all those variables we now have in our care? Further, how will any new system's billing process accommodate that increased time? How will it be audited? And it will be audited because it's government money. Fact of life. My dad used to say everything is related. The big problem is seeing the relationships. And the next episode is on the personalization of medicine and privacy. Time with the patient deals with the personalization of medicine. Medicine is far more personalized now than ever before, and that rate is not going down. It will not go down. The amount of time. In fact, I wouldn't be surprised if that 500 to 800 patient range actually shrunk a bit over the next 10, 20 years. It might be down to 400 to 600. Simply because of the fact we're going to have more dots to connect. Please do leave your comments below. Love to hear them. And I thank you for your time. And until next time, there you are.